Perhaps I'll start my talk this afternoon by telling you a bit of a story. Is that okay? A few months ago, actually, I was talking to one of my friends who's a medical doctor, and he works in a public hospital, and he was relating a story to me that earlier that week, a woman was brought into this hospital, and she was unconscious. So he was able to tell just from looking at her that she had recently undergone some surgery on the shoulder, but he was not able to tell anything else. He wasn't able to tell what was the reason for her surgery, what medication she was on, and that woman actually died there in front of him that morning. And while he said to me, in the condition that she came in, it was probably the likely outcome. That there was no other outcome. But he couldn't help wondering what would have happened if she had actually been taken to the facility where she had that surgery. Perhaps they would have been able to have a history of a condition. Perhaps they would have even been able to find the doctor that operated on her, and perhaps something else could have happened. That's just one problem I want to highlight. Let me highlight a couple of other problems as well. How many of you here, I'm sure many of you here have had an experience with our public health facilities. How many of you, maybe personally or through your family, have been to a clinic? A clinic visit is a whole day affair. It starts very early in the morning and it goes on for the whole day, right? I can hear from the giggles that you know what I'm talking about. And in fact, most of the time that you're spending at a clinic is actually just waiting. You're waiting for your patient file, you're waiting to be seen by a doctor, you're waiting for your medication. The third problem let me highlight is related to, in a recent article in the Business Day, the Minister of Health said that we have a situation in this country where a patient can go to a health facility, even the same health facility, or different health facilities 10 times in the single day, and nobody will even know that this is happening. And there are people that are actually doing this and collecting medication and starting a pharmacy at home. And there's no ways that the health system can actually pick this up. So the reason why I'm just highlighting some of these problems to you is these problems are examples that we're having with our health system at the moment that really, to be quite honest, we ought not to be happening in this day and age, because there are technologies out there that can actually help us to alleviate these problems. And the technologies that I'm talking about today are really information and communications technologies. And that really is the subject of my talk today, is around electronic health or e-health, which we can broadly define as the application of information and communications technologies for various health applications. Now, if I am indeed correct and say that we should not be having these kind of problems because of these technologies, the question then becomes, why do these problems still persist? What's preventing us from actually taking advantage of e-health in this country? And in his preamble to the National E-Health Strategy, the Minister of Health actually articulated two fundamental problems that are preventing us from making full use of information and communications technologies in health. The two problems that he highlighted were, number one, in most of our health facilities in the country, especially at the primary health care level in our clinics, we actually have no information and communication technologies. Everything that happens in those facilities is very much paper-based. And in most instances, you have a situation in our clinics where clinic staff are actually required to record everything on paper registers, sometimes as many as 56 different paper registers that they have to be filling in. So that's the first problem that we have, is just the lack of technology in our facilities. The second one relates to where we do have ICTs deployed in our facilities across the country. We have a problem with respect to those systems not being able to interoperate with each other. And those are the two fundamental problems that the minister highlighted that needed to be solved as part of the National E-Health Strategy. And I think in my talk today, I really want to focus on what is the CSIR actually doing to alleviate some of these two problems that have been identified by the minister in the E-Health Strategy. So I'll talk about 3 initiatives that are related to this. The first one relates to the Health Normative Standards Framework for Interoperability of e-health systems. Now, I already spoke about the issue of fragmentation of systems and systems not being able to speak to each other. How bad is this problem? In some initial work that we did, we found that across the country, there are at least 42 different information systems deployed in hospitals across the country. And none of these actually exchange information with each other. That is why we have the first problem that I spoke about with respect to this doctor not being able to retrieve this lady's health information, because these hospital systems just can't connect with each other. In fact, the problem is so bad that in 2009, the National Health Council decided to place a moratorium on the purchase of any new health information systems. And that moratorium is still in place today, 6 years later, which means this is compounding the problem in a sense, because now you have a situation that you're not able to actually put ICTs into clinics because of the moratorium, but you also have a situation where systems are deployed, they are aging systems and not being able to cope with what's required by the health system at the moment. So a few years ago, we engaged with the National Department of Health and said, we need to deal with this issue of interoperability or fragmentation of systems. And the first step that we need to put in place is actually put together a standards framework for interoperability of e-health systems in the country, which is called the Health Normative Standards Framework. What this essentially means is that what we're trying to do is to establish a common language that these different health information systems can speak. And in undertaking this project, we looked at all of the international developments in terms of e-health standards. We also looked at what's going on in South Africa in terms of what is required from our national indicator data set. We looked at the requirements from the National Health Insurance in terms of information. And we looked at our burden of disease scenarios as well. And based on all of that, we were able to come to a set of standards framework, which is, I think, relevant in the South African context. Now, the standards that we defined were in 7 different categories, ranging from the identifier of patients, which is critical in terms of making sure that we can actually get these different systems to talk to each other. We need to have a unique identifier that identifies you as a patient, irrespective of which facility you go to. The messaging of health records, content and structure of those records, coding terminologies, the electronic health record itself, security aspects, and other general IT standards. So those of you that are technically inclined can actually have a look at that on the slide. I'm not going to go through it in detail. The Health Normative Standards Framework was gazetted on the 23rd of April by 2014. And in his preamble to the Gazette, the Minister of Health said no IT system in this country will be considered for procurement or deployed in a health facility if it is not compliant to the Health Normative Standards Framework. So I think this was a critical building block in terms of establishing a set of a common language to deal with the issue of fragmentation of health information systems in the country. The second initiative I want to talk to you about is, now that we have the standards framework in place, it was important to now understand those systems that are deployed in the country, both in the public sector and in the private sector, to what extent do they actually comply to these standards. So we undertook a project with the National Department of Health, again, to look at compliance of health information systems that are deployed in the country to the standards framework. And we started off by looking at our primary healthcare facilities, typically our clinics. That piece of work has been completed. Right now, we are also looking at the systems that are deployed in hospitals, and that work is ongoing. So I'll speak very briefly about some of the results associated with the assessment that we did on primary healthcare systems. In addition to looking at compliance to standards, what we also did was actually defined what a primary healthcare patient information system should do, or how it should function in a clinic environment. So we defined an ideal set of requirements in terms of functionality, and we assessed these systems in terms of their ability to meet those functions. We also assess them in terms of their what we call non-functional requirements, which is around the look and feel of the system. How easy is it to use? What kind of training has been provided to personnel to use these systems? We also looked at it from a perspective of what kind of infrastructure is required to be able to use these systems. Do they need to be connected to the internet, for example? And so we did the assessment on 4 categories: the functional requirements, the non-functional requirements, the reliance on infrastructure, and of course the adherence to standards. So this graph just gives you an indication of how those systems fared against those 4 categories. I should also mention that we actually ran an open process to solicit vendors that were interested in having their systems assessed. Through that process and initial filtering, we ended up with 22 systems that we thought were eligible to go through this assessment process. And this graph gives you an indication of how those various systems fared against those 4 categories. I'm not going to go through this in detail, but the important findings from this graph is that when it comes to compliance to functional requirements and non-functional requirements, we don't have a shortage of good systems in this country. In fact, there are quite a number of good systems that have been deployed predominantly in the private sector. When it comes to infrastructure requirements, some of the systems are good, but there are also some that are built on aging technology and actually need to be phased out. And the big problem we found was that when it comes to adherence to the standards framework, that's when most systems actually fared very poorly. But of course, the vendors told us that we didn't know what the standards were, so how can we actually be compliant to them? So we're actually working with the vendors right now to make sure that we can get these systems to be compliant as well. The last project that I'll speak to you about today is the Health Patient Registration System, or HPRS. What the HPRS is, or seeks to establish, is a national database which is the authoritative source of patient demographic information. So that will be used for different purposes. For example, to enable the Department of Health to plan and provision health facilities, to identify members of the population when they come into a health facility, to be able to positively identify them, to be able to link the individual patients to their specific health records, and to support the tracking of patients across different facilities. So the Health Patient Registration System, I think maybe the simplest way to explain this is that it has essentially 2 parts. There's a front-end system, an application that is deployed in clinics, which enables the clinic staff to be able to register a patient the first time that person comes in. He presents his ID book, and the system then registers him. And when he comes in again, he's able to just produce his ID book, and the system picks him up again. So that's essentially the front end part of the system. But there's also a back end part, which is a national database that is situated here at the CSIR. And all patients that get registered at the different clinics, their details are also stored in a central database. So if you have a situation where a patient is actually moving from one facility to the next, and if those facilities are connected to the central HPRS system, then we've already been able to solve the problem of patients going to multiple facilities. Now we can pick up that this patient actually visited a different facility yesterday and the day before and the day before, because they are able to see the history of the patient visits on the national database. So, so we're very proud to say that this system has already been deployed in close to 100 NHI clinics in the country. Thus far, we've already recorded in excess of 500,000 patient visits and patient details. And we are planning with the National Department of Health to actually have this system deployed into all 700 NHI pilot clinics by the end of this financial year. The other interesting thing about this system is that it is able to generate a unique patient file number, which means that when a patient goes in there, and together with other initiatives that the Department of Health has put in place, it's very easy to actually retrieve the patient file. So instead of waiting 4 hours anymore to get your patient file when you visit a clinic, we're now able to, in some facilities, generate that patient file or retrieve that patient file in 4 minutes. In fact, I can probably tell you another story. One of our colleagues from the Department of Health visited 7 of these facilities where HPRS is deployed, and she posed as a patient. So she went to the first one and she registered herself as a patient. The process was smooth. There was no issues with respect to the training of the staff. The staff knew what they needed to do. And then she went to 7 or 6 other facilities to check whether she was able to pick herself up on the system. And she was able to in each of those 7 facilities. In fact, the longest it took for the system to pick up her details was 38 seconds. So I think from a perspective of creating greater efficiencies in clinics, the system is already having a major impact. The Department of Health is undertaking a monitoring and evaluation to look at what the impact of the system is, and we'll wait for those results. But certainly, other colleagues that have visited other facilities have told us that whereas in some instances clinics needed to stay open 6 o'clock, 7 o'clock in the evening just to get through all the patients, because of the inefficiencies that have been introduced in the system now, those same facilities are now able to close by 2 o'clock in the afternoon because they've already finished seeing all of their patients. So I think those are the 3 initiatives that I wanted to speak to you about today, and I think from a CSIR perspective, we recognize that there are some fundamental challenges in terms of the use of technology in our clinic environment, in terms of in our hospital environment. We also recognize that it's incumbent upon us as the CSIR to solve some of these technical problems. And I hope that I've just given you a small glimpse of some of the work that the CSIR is doing to actually address some of the fundamental issues with respect to the application of technology for healthcare. I think. So before I close, I just want to acknowledge, first of all, the National Department of Health, who's our partner in all of these initiatives, also the provincial departments of health that we work very closely with, and finally also to acknowledge the CSR team that is working on all of these projects. You guys are stars, and you work tirelessly on these over the last couple of years. And my job today is an easy one, is just to deliver a message of the good work that you are doing. So thank you very much.